a lot of slides. I tend to speak quickly. I can pivot. I can kind of extend if we want to land somewhere and talk about it more. But I'm just very, very excited to be here. Y'all are like superstars in the comp cancer world. We draw on your work all the time to try to share best practices. You have so many superstars in your leadership. I stole one of them, who's now working for me. So I'm just really pleased to be here and have been wanting to come visit for a while. So I'm super excited to be able to speak with you for a few minutes today, and hopefully, oh, there we go. Those are my pronouns. So this used to be more novel. I think people are getting used to this now, but I originally started sharing my pronouns during presentations just to point out kind of all of the ways that we have assumptions when we meet people. And I will say, we had a chat this morning at breakfast, and there's a couple of key things that I always try to convey. And the first thing is just being aware of your assumptions, right? Like what are our assumptions? Can we suspend them and make space for what we're actually encountering in the moment? So my pronouns are she and her. Okay, so these are the big kind of themes that I'm going to kind of get to today. But like I said, I'm doing a lot of work in this space in a lot of different areas. So I could talk all day about this, but I'm going to start with basic terminology because I get that not all of us live in this space all the time. And then talk a little bit about lived experiences and social structures that affect health outcomes, unique risk factors, screening considerations, and other care considerations for queer populations. And then I always leave resources, because what's the point of knowing stuff if you can't do anything, right? So terminology, if we were in a workshop, I would ask you what these letters meant so that, the whole adult learning principle. But since we're in a lecture, I will just share, these are flattened definitions, right? We're never gonna have perfect definitions. I mean, I think one of the things about being in the queer community, we don't like boxes. We don't really like, so it's like all of this is like subject to evolution. But generally, when someone refers to a lesbian, it's a woman who has primary romantic and sexual feelings toward women. Gay could be male-male, same-sex attraction, or female-female, or woman-woman, and we'll talk a little bit about that in terms of what's the difference between female and woman. Bisexual, someone who's attracted to both or any sex. Transgender, someone who doesn't identify with their sex recorded at birth. So their gender experience is different from their sex recorded on their birth certificate, theoretically, assuming they have a birth certificate, yeah. Queer is kind of an umbrella term. I embrace queer because when I was in 4th grade, all the people insulted us by calling people queer, and I liked reclaiming things. So, and I also, to be honest, I came out rather late in life. Well, for me, I felt like it was. I was 32. And I've dated women, I've dated trans men, I've dated non-binary people, and queer felt more affirming to me rather than trying to kind of tangle my way around what does this actually mean and is it affirming to the person that I'm with. Intersex is something we haven't talked about a lot, and it was kind of like really not discussed, but actually we have about the same percentage of intersex individuals as we have trans individuals. There's a little bit, I think there's a slightly higher intersex population, but these are individuals that have male and female sex characteristics. They could be, I want to say 10 to 20% are actually visible at birth, but sometimes, many times, most times, folks don't know that they may have male and female sex characteristics until they try to become pregnant, or something else happens that, where there's an X-ray or something that shows that they may have ovaries and testes or something like that. So like about 1.7% of the population has intersex characteristics, and historically this has been very pathologized and not discussed, and thankfully we are moving a bit and turning the corner on that, because there are important medical considerations for people based on their organs. So this slide, I'm not going to read all the things because I won't pronounce things correctly, but the idea is just to share that we have a lot of different terms based on our intersectionality, and if that's probably a term that you've heard, but the idea behind intersectionality is that we're not one thing, right? I'm a cisgender white female who used to think I had a history of Native American blood because that's what my parents told me, even though it's not true. 23andMe corrected that for me. And I'm a mom, I'm a boss, I'm a daughter. I came from a rural background. I now live in a more urban background. So all of those things comprise my lived experience. And we have different words in different cultures for sexual and gender minority kind of umbrella experiences, and not all of them are one-to-one. And frankly, LGBT is pretty white. Like it's kind of a more white terminology that not all cultures really ascribe to, but it's kind of what's most familiar. So the Office of Sexual and Gender Minority Health at NIH chose sexual and gender minority health to be more of an umbrella term so that we're being more inclusive, and yet it's a made-up term. Nobody in the community actually says that. So clinicians and researchers say SGM. Queer folk don't usually say that. So anyway, we have a lot of terms. I did say I was going to come back to sex and gender and terminology there. I do want to just emphasize that female and male are typically terms that refer to recorded sex, and woman and man typically are defining a gender experience. And so one of the projects I'll talk about in a little bit is about refining the kinds of measures and words we're using to ask questions so that we're actually asking about the construct we're interested in. More on intersectionality. I mean, at the core, I think, to me, you can't talk about intersectionality without talking about power. And we all have power, and we all feel disempowered at times, and it doesn't mean that all of us have the same amount of power, or even over time or throughout our lifetime have distributed the same amount of power, but we do have some power, more power than at other times, depending on the circle we're in. So we may have a lot of authority at church, or we may have a lot of authority at school, or in our professional lives, or in our household, and we may feel not that way in other settings. And so when we're thinking about healthcare, I think it's helpful, and outreach, and engagement, and public health work, I think it's helpful to just reflect on what are the ways that you experience power, just to really think about that, and in what ways might you sometimes feel vulnerable. How does your positionality reflect your how is that associated with your health, and how does it affect your health? And then if you can take the next step to think about, okay, you're interacting with people from all of these different experiences, all of these different backgrounds. No one is the same. How might their experiences differ from yours, and what might the interaction that you have, how might that feed into feelings of vulnerability or feelings of confidence and empowerment in our public health work? So this could be an entire year training, but something to reflect on and continue to learn about. Sorry. I feel less expert with the clicker today. Sorry, guys. So this is an article that I found right before I was about to lecture for a public health class, and I was thinking, I don't understand, stress, everyone has stress. How is it, we talk about stress and cancer, but I'm well, stress can't cause cancer, right? What is that relationship like? And so this article was actually really helpful to me because I was it's not that stress causes cancer, it's that we have cancer circulating we have aberrations circulating all the time in our systems, and when we're immunocompromised or we are under experiences where we're on high alert, we're under experiences that are triggering trauma, or where we don't feel welcome, we don't feel supported, and especially if that happens over and over and over again, our systems can't deal with how to address those aberrations most effectively. And sometimes when there are latent cancer cells, this particular study showed that, okay, it's mice, but still, that, stress had the cancer cells come alive, right? So it's we have these different, we have all this stuff happening in our system, but we need to have a healthy immune system and feel supported and feel okay in order to have that optimized, right? So it's not that stress causes cancer, but it can create a laboratory where cancer can thrive, where in other contexts, maybe it wouldn't. And so what does this have to do with public health and what I'm talking about in terms of queer health? So hopefully this is familiar to you. I know that probably the words are a little small, but social determinants of health really are about where we work, where we play, where we live, where we worship, who we interact with, what kind of education we have, what kind of economic stability we have, whether we have reliable food sources, if we have places where we can exercise, whether we have access to the healthcare system, have coverage, feel comfortable in the healthcare system. And this is not new information, right? Like, this is information we know that it's not race that causes racial disparities, it's racism, right? I mean, it's not being queer that causes cancer disparities. It's transphobia, it's homophobia, it's stigma, it's the experience of not knowing if you're welcome, having to be hypervigilant, and in many cases, or at least historically, in the queer community, some of the social determinants of health, particularly in the trans community, has been homelessness because of family rejection, right? You're not homeless because you're trans, you're homeless because you're rejected by your family, or, income because of discrimination, or, perceptions of what's appropriate in terms of style and hair and mannerism. Insurance coverage. So until the Burwell decision in the Supreme Court in 2015, a lot of queer people had disparate insurance coverage, right? So if you were in a long-term same-sex relationship, depending on where you lived, you may not have access to spousal or partner coverage, which had a big impact on access to care. That's improved since that Supreme Court decision, but as you know, we are kind of under a pretty intense full court press in terms of trying to unwind some of those protections. Food insecurity. Another study that I'm working on at GW that's local is really around social determinants of health, and as people are finishing cancer treatment, like, do they have the social support? Do they have housing? Do they have transportation? Have they had to stay in someone else's home in the last month? And so these types of things, homelessness, food insecurity, these other kinds of basic life, quality of life issues have fundamental impacts on whether, like, how well we do, how quickly we get into healthcare, how well we do when we leave our treatment management and our acute in our episodes of care. And then access to care, right? Like, I mean, I can't tell you how many people in my life, well, first I'll start with data. So I did a research study on transgender cancer-related and healthcare-related experiences in the DC area. And what I found, and again, it was a smallish sample, 20-ish, 22 people, and for some reason, trans women had pretty good healthcare experiences, and I think that probably had a lot to do with some of the resources in our region. Women Walker's a fantastic facility, and the history in that community that particular clinic has provided care for. But trans men are like less likely, and this is anecdotal, you can prove me wrong, do a study and prove me wrong, but in my experience, seem to be less networked, less connected, more isolated. And so trans men in my sample were like, I'm not going to the hospital unless I'm about to die. Like, I'm not gonna, like, that gyne clinic is not for me. That breast clinic is not for me. That women's center is not for me. The ER, they're gonna ask me weird questions. Like, unless I'm in excruciating pain or about to die, I'm not going. So, access to care isn't just where things are located, but whether people feel like it's going to be more awkward to have a care experience than to just avoid it altogether, and what that cost-benefit kind of calculation looks like. So, minority stress, we hopefully know a little bit about this from all of the research in kind of racial and ethnic disparities and discrimination in this country, but we know that from minority stress, we have higher levels of stress that are anticipated, right, from experiences of interpersonal prejudice or anticipation of discrimination, lack of social support. A lot of times we have different kinds of social networks in the queer community because we need to, because historically, sometimes our biological families haven't been our sources of support. So, and then low socioeconomic status, I mean, again, when you're kind of hit with, do you have family support? Do you have a supportive environment? Do you have a school where you're seen? Do you have a hospital where you're seen? Do you feel like you belong? And then what are the employment and educational opportunities in front of you? All of those things come into play. So now I'm going to pivot just for a slide to what can we do about it? Because I don't want to just leave you with a whole lot of depressing stuff. So screening for minority stress, we can ask people in order to kind of identify and build that trust, like, what have you been through? Like, how comfortable do you feel navigating the world, and do you feel like you have had negative experiences because of some part of your identity or something that's important to you in terms of how you present in the world or are identified by others in the world? And then not just stopping there, but how have you coped with things in the past? What is your social support network? How have you dealt with stressful situations historically? And can you tap into that resiliency? Can you tap into those sources of positive support, joy, belonging, to help get people to identify, where can I thrive and how can I use that in my experience now? Another strategy, trauma-informed care, right? So trauma is about experiencing direct threats or witnessing someone who has experienced something very frightening or potentially life compromising, or learning about events. So I mentioned this in the breakfast conversation we had, but I had someone call me not that long ago and say, tell me all the bad things you've heard about queer health. And I'm like, ouch. So I talk about this, and I'm happy to talk about this because I'm in a position where I feel like most of the time I'm less traumatized talking about it than maybe the case. For other communities where they may not have paid time off from work, or so I'm happy to talk about it, but it is still exhausting, and it's still when you revisit and revisit and revisit, it's important to be able to share those experiences, but it's also important to acknowledge that having that repeated exposure and recalling of negative things is not benign. Right? So those are ways in which trauma comes into health and health care experiences. Again, these are tiny fonts, sorry, but about 80% of LGBT youth have said they've been discriminated against. And I really don't want to enforce a negative stereotype here, but I think this is an important statistic, at least as of 2014, to mention that almost half of bisexual women, men, and transgender individuals had experienced sexual violence, because we hear things like, I kid you not, I have heard things walking along a street, just going to get coffee, that were extremely obnoxious, where people thought they could change my sexual orientation by assaulting me, right? If they didn't assault me, but they did verbally. And so this happens a lot. And so it's not being queer that makes that statistic true. It's the stigma and the kind of hatred and kind of license to be hateful, I think, that results in those statistics. So there is a lot of trauma in our community. And so what do you do about it? Trauma-informed care, you're don't dismiss it, right? Don't dismiss it, don't write it off. Oh, you're overreacting. Oh, that's not so bad. Oh, well, at least this didn't happen to you. So acknowledge, recognize, recognize both at the personal and at the system level, right? That there's a widespread, broad effect of trauma. And frankly, it hurts all of us, all of the forms of discrimination that we see in this country, right? That's all traumatic. So we're carrying that as a collective. And then you add interpersonal experiences and your own internalized. For 2 years after I came out, I thought I was a straight girl that dated women. I was it was so foreign to me to call myself queer, or to just structurally, cognitively, I was no, I'm a straight person, except that I'm not. So how does that affect our psyche at the internal level, interpersonal level, structural level? And how are our systems in place? Well, who are they built for? And are they affirming environments? Things aren't gonna change on their own. They were built a certain way for a certain outcome, and we're seeing the outcome. So we have to intentionally choose another path and be part of a revised system in order for there to be different outcomes. And then making sure that we're not adding to the trauma, right? So preventing further negative trauma. And some of these things that we can do are, avoiding harm, reinforcing harm, validating feelings, and even if you wouldn't feel that way, it doesn't negate the fact someone in front of you is feeling a certain way, right? Avoiding blatant discrimination, acknowledging our blindness and blind spots in terms of implicit bias. Oh my God, I can't even tell you. Like doing this work, sometimes something's come out of my mouth and I'm like, oh boy, and I'm trying to be an advocate and I'm part of the community, right? So it's like examining that and at least being honest and trying to continually work on our own, the impact of what we do and not just the intention, because the impact matters. Acknowledging lack of data, this is a huge problem, and we need to do this safely, but I'll talk about this a little bit more to come. So risk reduction in affirming environments, what can we do here? So avoid, this is gonna be a lot of tips for the next little bit. Avoid gossiping, I mentioned this earlier, but avoid trivializing concerns. Avoid claiming sexual orientation and gender identity is irrelevant. Advocate where you can at the system level in terms of electronic health record documentation, education to clinicians and staff in terms of why is this important. I have training to do in my own shop in terms of ask these questions and don't giggle. You need to be helping to normalize these questions so people feel welcome. Because there's a big assumption there if you ask a question about sexual orientation and you laugh while you're doing it. Reduce system-level aggressions where you see them. And this is a little tricky. Yes, we have higher alcohol use. Yes, we have higher tobacco use. Yes, we have higher substance use. And the reason for that is because we have higher stress and we have distress from being socially excluded and societal trauma and decades of marketing from tobacco and alcohol. I mean, how much alcohol is involved in pride? I mean, I love pride, I love wine, but it's intentional, right? So let's be clear that we don't have higher rates because of, again, something to do with our queerness. We have higher rates of these kinds of coping mechanisms because we're trying to get through our day, right? We're trying to be okay. Reflect on our own biases, use terms, just create the space so that you're hearing, and use the terms the patient is using rather than what you're assuming. Other strategies, and a lot of these are coming from the Healthcare Equality Index from the HRC. You can see that little, the logo there. The HEI is an opportunity for institutions to stand up and say, at least we're trying. We're trying to do some things to show that we care. And some of those things are, we're gonna publicly post non-discrimination policies that include sexual orientation and gender identity so people formally know that they can appeal, and there's an expectation that you don't discriminate on the basis of sexual orientation and gender identity. Inclusive posters, inclusive brochures, information that is conveyed in a way that lets people know they're the intended recipient of that information. There was a cool study, and this is, as a scientist, I should know better than to just say, I don't remember where I read it, but there was a recent cool study that talked about how queer people, we don't want to just see people that look exactly like us. We want to see people from every race, ethnicity, geography, religion, nationality, across the LGBT spectrum, because we're not one. We're not monolithic. I don't represent all the queer people. We're so diverse, right? We want to see all of the diversity that you are welcoming in the door. And that makes us feel more affirmed, not less. I don't want to see 90 pictures of Mandi. I want to see something that shows that I'm welcome and 89 other pictures showing that everyone else I love are welcome too. So here's some options. I think some of these are cute. Options, I mean, get yelled at, get beat up. That's actually kind of not funny. I have people really important to me that have known, one friend of mine used to work on repairing bikes in DC, and they knew every gender-neutral bathroom in the city because they knew whether they would get yelled at or if they would be able to go to the bathroom. And so, it's kind of funny, but it's not. But putting up kind of messaging where you can say, hey, I mean, yes, even if you have gendered bathrooms, male, female, have at least another place where it's gender neutral. Or, I mean, put a piece of paper over the sign and make it gender neutral. One of my favorite things was I was asked to talk at a really big cancer center one time, And one of the DEI AD used it as an opportunity to make the janitorial staff change the bathroom signs before I got there. I was like, yes, that is what I'm talking about, advocacy. He's like, we have this spear coming in, and I think we really need to have a gender-neutral bathroom. I'm like, whatever you need to do, use me, it's fine. I thought that was fantastic. So in terms of the EHR, I'm doing a study right now with a wonderful friend of mine, Dr. Charles Kamen in New York at Rochester, and Megan Millens at UT Southwestern, and we are looking at sexual orientation and gender identity data collection in oncology practices. We have 62 interviews from 22 practices, and we're looking at implementation factors, what makes an institution decide to collect and use sexual orientation and gender identity data from institutions that do not. So we are currently doing that analysis, but this is a screenshot of just an imperfect but better than typical inventory in the EHR that allows for documentation of sexual orientation, allows for documentation of gender identity and pronouns, has an organ inventory, which I'll talk a little bit more about in a second. But how do we know what to screen for if we don't know what body parts our patients have? So here are, again, these are just so tip of the iceberg, but like in terms of terms to use and terms to be aware of. Chosen name, so how, or name and use. I kind of tend to favor name and use. Well, or just what do you want to be called? How should I refer to you? Like, my name is Mandi, how would you like me to refer to you? And one of the cool things in one of my qualitative studies that I found was this one really big institution pivoted when they realized that cisgender men named Jonathan wanted to be called John, right? Like, it's like, it doesn't have to always be a queer issue to be a patient-centered issue, although this is a queer issue too, right? So like really honoring, what does someone want to be called? They're in a scary place, right? So how do you make them more comfortable and be respectful of who they are? Gender, sex assigned at birth, sometimes sex recorded at birth. This language is in flux. Like, we are going to, my daughter's generation is going to have all kinds of, they're going to be like, you sounded so dumb when you said that. But like, we're evolving, right? So it's going to change. Pronouns, transition experience. Avoid saying, where are you in transition, or did you transition, or is it clinically relevant? Like, ask the questions that are clinically relevant, and don't assume there's an endpoint with everybody on a trajectory to that endpoint. Dead naming is a huge problem. So if someone has a name on their insurance or sometimes on their license, and you call out in a waiting room, and they're sitting there and they don't look like Richard, and I have friends who have left. They've just chosen to not get the medical care that they needed because it was so embarrassing. So being aware of having a place on intake, like, just how should we refer to you? How should we call you into the room? So cancer screening considerations. These are kind of dated, but honestly, UCSF did the first kind of comprehensive sweep of primary care considerations for transgender care. I don't think they've been updated, but it still gives you some just common sense tips around, okay, do you have the body part? Are you at a risk factor, based on age, based on endogenous or exogenous hormones, like taking into account some of these things. So there have been a few updates since then. I've written an article with Jenny Potter in 2019 that I asked the consortium leadership to make available to you that summarizes some of these things. And the American College of Radiology actually in 2021 or 2022 came out with some case examples for breast imaging around different factors. So degree of breast tissue, age, endogenous hormones, exogenous hormones, and how you might think through some of those things. So we have some evidence that is building and some guidance that is building, but we still don't have gold standard evidence because we don't collect the data, right? So like, we have organizations, panels, guideline driving organizations like the U.S. Preventive Services Task Force. They issued an op-ed, I don't know if it's op-ed, but like a kind of disclosure of, in the future, we're going to be looking at sex and gender and how it affects our guidelines, but we're never really going to get to the strongest clinical evidence if it's always anecdotal, right? So this is why collection of sexual orientation and gender identity is so critical in a safe space. So I would say second point. First point, be aware of your assumptions. Make space for what you might not assume immediately. Second major point, institution should make this a requirement for the institution, not for patients. For the institution to offer, to have a place to document, to train people why it's important, not to force patients to respond. Because we're in a political reality where that can be scary and life-compromising. So advocate for it being a mandate for the institution, not for the person, not for the patient. So what do we need for evidence-based care, better evidence-based care? We need to be able to ask and understand how to ask about sexual orientation, gender identity. We need to know where to store, how to store this information. We need providers that are both clinically and culturally competent. We need space for people to say who they are in their patient portal, on intake forms, in the brochures and posters and education they see. And we need some billing specialist knowledge so that there aren't intentional kind of claim denials based on gender marker, and we can smooth those processes for early detection, particularly for trans and intersex individuals. So the next, I know I'm running short on time and there's so many slides, but I have a number of key takeaways that I want to kind of emphasize, so I enumerated them. The first kind of fact, you can challenge me on this if you'd like, but is we don't ask about SOGI, right? We don't ask about sexual orientation and gender identity. I was first author in this article in 2022 that I wrote with about 19 other wonderful colleagues across the country. And the point that we were trying to make in this piece was all research is LGBT research because we come from every background, every walk of life. And if we are gonna just say, oh, well, it's not an LGBT study, we have to replicate every single study that we do, intentionally find queer people, and then see if it still works, right? Like, what does that even look like? Like, queer people are from everywhere, right? So just start asking the questions so we can start looking at the data across studies and we can start to guide clinical care in a more, in a better way. And also, it's a better use of research dollars, right? Like, why should we have to duplicate studies over and over and over again when we could add a demographic question or two to all of our studies? Point two, we don't know how to ask these questions. So the National Academies of Science, Engineering, and Medicine issued this report measuring sex, gender, identity, and sexual orientation. I publicized it and distributed it in a webinar with my lovely colleague, Kellen Baker, whom I adore. But a number of us, despite kind of appreciating the step, like didn't totally love what the guidance was. And why is that true? Because the worst kind of example was their gender identity questions. So the gender identity question was, select one, male, female, transgender. So first of all, there's no face validity, right? Like you can be a trans female, a trans male, you are either cisgender or transgender. Female refers to sex, not gender. Male refers to sex, not gender. So there was just so many things wrong with this question. However, the reason the National Academies released it is because they could only look at what was in the literature. And so if we ask things in a way that is imprecise and we ask things that are not coming from the lived experiences of people that we're trying to, we are trying to do better for, right? We need to expand the we, and we need to include perspectives to make sure that we're getting the constructs right rather than building on shifting sand. Thank you to my evangelical background for that parable I just recalled. So we have I've worked with about 6 other colleagues, and we have a piece that is preliminarily accepted. I guess I shouldn't jinx myself by saying the journal, but talking about refinements to the way that these items are measured and rationale behind why we would recommend some adjustments to the NASEM measures. And because we lock ourselves in, we're like, oh, this is how we've done it, so we're going to do it this way, but then we want different outcomes, but we're going to do it this way because this is how we've done it. So we're making the argument, no, we should do it. We should evolve beyond that. Number 3, we don't have a reliable way to document SOGI. So one of the things in the work that I've been doing in this implementation study is that one of the key drivers of whether people collect data or not are like, where do I store it? Where do I even put it if I ask the question? So, this was a qualitative study that I published in January because a colleague of mine said, hey, can you write something about gender identity and radiation oncology? And I said, sure, I can write about anything. So I went to PubMed and I'm like, gender, identity, radiation, nothing, like cancer, like nothing, literally nothing. And so I was like, oh, I have to do a study then. So I grabbed the head of our radiation oncology department and a radiologist that was new at GW at the time, and we recruited wonderful volunteer physicians who were willing to talk about their experiences and what they were not confident about and what they'd been trained on and what they hadn't been. And one of the things that was mentioned was, you need all of this data to roll up, and when the fields aren't structured and the fields don't match and they can't talk to each other, this and everything is binary, this becomes a problem in terms of being able to document these data. Other things that we found in the study, patients who identify, queer patients, sexual and gender minority patients face challenges at every step of the healthcare system. So scheduling and registration, assumptions about voices, assumptions about names, environment, whether they look, whether we're included on images, consultation. I'll get through that in a second. So in terms of like scheduling registration, again, binary, we have 2 boxes, male, female, that's it. In terms of environment, we gender things so much, like in the breast clinic, it's pink, it has the word woman everywhere. So these are actual quotations from the physicians that I interviewed. And again, this was published open access in January of this year, if you want to look it up. But these are the testimonies that I got. In terms of consultation, I felt mildly uncomfortable. So this is someone who identified as a gay man, who's very out at work, and everybody just assumed that he knew about transgender care because he was part of the LGBT community. We're all very different. We have really different experiences. And this person was very uncomfortable because he felt like he was supposed to know all of the things as the representative queer person that was out at work. But he hadn't been trained in terms of clinical consultation and what kinds of things might be important in that encounter with someone that might have exogenous and endogenous hormone balance that's different from what they've typically seen. Oops, I'm sorry. Oh, I messed that up. I get to go backwards in my slides. I don't know how I jumped ahead so far. Oh, yeah. Feels like, yeah, okay. What if I just, no? Let me go back. Sorry, guys. Okay, and then, I think there's one more back. Right, billing. When I asked about billing, I had one radiation oncologist say, oh my gosh, I've never even thought about that. I've never even thought about billing considerations and whether, depending on whether someone is coming in and has different body parts than what is assumed at presentation, potentially how that might affect whether gender marker mismatches would affect their out-of-pocket costs. Supportive care, this radiologist said, and this was a study, I was trying to be succinct, but it was a study of radiologists and radiation oncologists to look across the spectrum of experiences in trans care. And this particular radiologist said, well, if there's something I'm supposed to know, I don't know it. So I'd love to know it, but I don't know it. So, and that was very common in terms of what we heard. So key takeaways from my many key takeaways. In terms of affirming environment, revise your intake forms. Just do it. Just go back, add what do you want to be called? Legal name, what's on your insurance. Explain if you have to ask or you have to refer to someone based on their insurance card. Just put a sentence saying, we're referring this way in order to optimize your reimbursement for insurance. Explain why you're doing it so it just doesn't seem like people are being ignored. Visual displays, I've talked about a number of times. Safety. Create moments and moments and moments and repeat moments of allowing people to disclose and not feeling like they're going to be punished, discriminated against, or someone's going to walk out of the room or send them to psychiatry. make sure people are culturally and clinically trained and have ongoing cultural and clinical training in LGBT care. And we talked about this morning too at the conversation I had at breakfast. Exposure. So whether it's an out clinician or out kind of leadership at your institution or panels from people in the community organizations, hearing those stories of people and how they're affected can go a long way in terms of the some of that training. And then making sure that we're supportive of the sources of social support that our patients indicate. So I've had kind of anecdotes, people tell me that, oh, well, as soon as I mentioned this was my wife, my provider, just ignored her or whatever. And so making sure we're honoring the sources of support that people indicate are important to them. Reflecting the patient's words, being patient, that's again creating space to allow for a response. Open body language, following the patient lead in terms of eye contact. This is super tricky because culturally we're all over the place, right? Different cultures, we have different expectations. Sometimes it's rude, sometimes it's rude to make eye contact, sometimes it's rude not to, so just following the patient's lead, looking up from your screen, suspending judgment, remaining non-judgmental and professional. Third major takeaway in terms of remaining professional, the healthcare encounter is not bidirectional. The healthcare encounter is for the patient. And so it is not up to the patient to make the provider comfortable. It's about the provider creating a space to optimize the wellness of the patient. Ways to check your assumptions. This goes back to the key point one. Just thinking about what are my immediate reactions and how might that influence the person in front of me? What am I assuming? Am I assuming straight cisgender status? Am I assuming a particular caregiver? Don't ask questions because you're curious. Ask because they're clinically relevant, right? Don't make someone feel like they're on display at a circus and that you're bringing 10 medical students in because you don't see this very often. Other resources, I've given the consortium leadership these resources to distribute to you. So one of them is just a simple kind of form that you can give to patients. You can adapt it, you can change it, you can tear it up, you can put your logo on it, you can co-brand it with GW, you can take GW off, I don't care what you do. But there's options for name, pronouns, religious preference, if any, caregiver preference, things people are worried about that they think might get in the way of their care. A welcome poster in 7 languages with a rainbow. Tips in terms of thinking about and practicing communication strategies. And then this is the article I mentioned that I wrote with Jenny Potter in 2019, just kind of walking through the spectrum of care considerations. So kind of a recap of some of the things that I've talked about today is getting a little bit dated, but it is a starting point. I mentioned the standards for cultural competency training that I worked on with a number of colleagues. So definitely would recommend that. That's in LGBT health and open access. So this is a training, this is my passion project that I don't have funding for right now, but I developed with 12 amazing friends and colleagues about 17 hours of content around health equity. And actually, I believe the foundation of it was our team training, which I believe Tamika was one of our first speakers that we did a couple of live trainings for Together, Equitable, Accessible, Meaningful. And then we put that content online, which still has CME through the end of this calendar year, will be accessible thereafter, but not with CME necessarily. And then we built on top of that some specific content around risk reduction, screening, trauma-informed care, communication, insurance landscape, policy landscape, supportive care, palliative care. So I have a whole bunch of content that I'm trying to make more case-based, more adult user-friendly, but it's there, and if anybody wants to see anything, or I'm happy to talk about it anytime. But eventually it will become public access. I just haven't been able to do it yet. Fenway also has a number of mini videos that you might check out. The LGBT Cancer Network has a lot of great resources, including webinars, infographics, free media. They also have this Welcoming Spaces training, which is super cool and is free, I guess, in 2022. So I don't know if it's still free, but there are CME, and this is a CDC-funded project. I definitely recommend this training. And then I will leave you with a call to action. So This was also a quotation from the study I mentioned was published in January and kind of channeled something that I try to communicate at the end of all of my talks, so I liked the quotation. This gynecologist said, I think my role as a doctor is also to set the example for other staff as to what's appropriate, because setting ground rules is being the one who's asked the patient what they like, disseminating that information, being an advocate for them, and a champion for this type of practice in your setting. And I would just invite you all to think about what can you change where you are, whenever you can, and to stand up. And as I mentioned this morning, I can't name one holiday that is celebrated because someone followed the rules. Almost all of it was because we saw something wrong and someone did something different.